All right, hello everybody. So my task today is to talk to you about tricuspid and pulmonary valve disease and the new guidelines. So just to give you an overview of what we're going to be covering in this presentation. So I prepared this slide. We're going to be talking about the tricuspid valve, imaging of the tricuspid valve, and we'll talk about tricuspid valve dysfunction in terms of regurgitation, stenosis. Then we'll move to the pulmonary valve, talk about imaging of the pulmonary valve, and assessment of regurgitation and stenosis. Obviously, we know much more about the tricuspid valve, so this section actually fills up more of the talk. So the normal tricuspid valve complex is made up of three leaflets: the anterior leaflet, which is the largest leaflet, the posterior leaflet, and the septal leaflet. The septal leaflet is really the smallest of all the leaflets. It's also made up of the fibrous annulus, the chordae tendineae, the papillary muscles, the right atrial myocardium, and the right ventricular myocardium. The tricuspid annulus, just like the mitral annulus, is saddle-shaped. In any one of the standard views used to visualize the tricuspid valve on 2D echocardiography, really only two leaflets out of the three leaflets are routinely imaged. And sometimes you are able to catch all three leaflets at the same time. With 3D echocardiography, it's possible to appreciate all three leaflets of the tricuspid valve simultaneously. This is a view of the tricuspid valve using 3D narrow angle mode from the right ventricular perspective. You can see that the septal leaflet is in the 6 o'clock position, as is the convention. This is the anterior leaflet here and the posterior leaflet here. This is the tricuspid valve as viewed from the right atrial perspective in the same patient. Septal leaflet once again in the 6 o'clock position, posterior leaflet here, anterior leaflet here. One of the things we have learned with 3D echocardiography is that you really cannot be sure which leaflet you are imaging on 2D echocardiography. For instance, look at this slide. There are two apical four-chamber views. They look just about identical. This is actually a full volume data set in a normal subject. This apical four-chamber view is cutting the septal and posterior leaflets, whereas this apical four-chamber view is actually cutting through the septal and anterior leaflets. You cannot tell the difference when you look at these two four-chamber views. So how do we target specific leaflets of the tricuspid valve to be sure which leaflet we are actually imaging? Well, one way is to perform imaging in which you target the tricuspid valves based on leaflets based on landmarks. Here you can see some examples. So this is the RV inflow view with the septum in view, with the coronary sinus in view. When you see that, you are imaging the septal and the anterior leaflets. In the apical five-chamber view with the left ventricular outflow tract in view, you are imaging the septal and anterior leaflets. If you are able to get very posterior so that you can see the coronary sinus, here you would be imaging the septal and posterior leaflets. With the short axis view, really, it is very difficult to be sure which leaflets you are imaging because oftentimes you cut through all three leaflets. If you see a single leaflet in the short axis view, you are imaging the anterior leaflet. Let's move to the echocardiographic assessment of the tricuspid valve. Now here you see a list of all the essential elements that go into comprehensive assessment of the tricuspid valve. We start with the leaflets. When we look at the leaflets, we think about, are they prolapsing? Are they flail? Are they thickened, restricted? What's wrong with the coaptation? Is anything wrong with the coaptation? Is there tethering? Then we talk about the annulus, the right atrial size, right ventricular size and function. We look at the tricuspid valve itself, look for any evidence of tricuspid stenosis or regurgitation. We measure the systolic PA pressure, and we look for any associated left-sided heart disease. Now, both 3 and 4 are covered by other lectures in this series, and both 6 and 7 are also covered elsewhere. So we will focus really on 1, 2, and 5. So the leaflets. This is a patient with a primary abnormality of the tricuspid valve. You can see on 2D echocardiography that the leaflets are very myxomatous and thick. You can appreciate even on 2D echocardiography that there's prolapsing of the leaflets that you see. And if you look on the side here, the mitral valve also appears myxomatous and thickened. On 3D echocardiography, you can appreciate prolapse of all three leaflets. The most common cause of tricuspid regurgitation is of primary tricuspid regurgitation, and we'll talk a little bit about that definition, is myxomatous degeneration. This abnormality is seen in 20% of patients with concomitant mitral valve prolapse. This is a patient who had blunt closed chest trauma. An example would be a motor vehicle accident. You can see here that there is a rib fracture on the x-ray, and the tricuspid valve anterior leaflet is completely flail. Now, this is a common question on the exam, so it's something that you want to remember. Here is another iatrogenic cause for tricuspid regurgitation. Again, a cause of primary or organic tricuspid regurgitation. This patient, as you can see on two-dimensional echocardiography, this is being the four-chamber view and this is the short axis view, there is significant tricuspid regurgitation. Here you can see the pacemaker wire is impinging on the septal leaflet. This is looking at the tricuspid valve once again from the right ventricular perspective, septal leaflet here, anterior and posterior leaflets here. And if you look at intraoperatively, that pacemaker lead is completely encased in the septal leaflet. You cannot separate the two from each other. So what the surgeon did was he took the lead, put it in the posteroseptal commissure and sutured around it. And that's why the tricuspid valve looks like this post-op. Here is another primary cause for tricuspid regurgitation. The leaflets here look very rigid, stiffened in appearance, and there is some retraction of the overall leaflet length, as you can see here, resulting in failure of coaptation and tricuspid regurgitation on this basis. This is carcinoid heart disease. It is something you have to imprint onto your brain. It occurs when an endocrine secreting tumor releases high levels of serotonin and its metabolites, such as 5-hydroxytryptophan, into the bloodstream. This results in an inflammatory reaction on the endothelial surface of valves and the endocardium, with a predilection for the tricuspid valve and lesser involvement of the pulmonary valve. So this active metabolite is deactivated in the lungs so that in the pulmonary vein blood flow, you don't find this metabolite. And that is important because this spares the left-sided heart structures. So the most commonly affected valve is the tricuspid valve. So let's take a moment here to look at the mechanisms of tricuspid regurgitation. So tricuspid regurgitation can be caused by primary causes or organic cause of tricuspid regurgitation. This accounts for 15 to 30% of tricuspid regurgitation, and we saw some examples in the previous slides, including myxomatous disease, rheumatic disease, endocarditis, carcinoid chest wall trauma, biopsy-related damage to the tricuspid valve, and lead-related damage to the tricuspid valve. There are also congenital causes of primary tricuspid regurgitation, including repaired tetralogy of Fallot, Ebstein's anomaly, and tricuspid valve dysplasia, and so forth. Now, secondary tricuspid regurgitation, which really includes both these categories here, accounts for 70 to 75% of tricuspid regurgitation, so it's far more common. We divide it into these two categories. I'll explain that in a little bit. But with secondary tricuspid regurgitation, we are talking about typically right ventricular enlargement, papillary muscle displacement, tricuspid valve tethering, and annulus dilation, as you can see here. The other time in which you can find tricuspid regurgitation is if you have atrial fibrillation, enlargement of the right atrium, resulting in dilation of the tricuspid annulus and tricuspid regurgitation. These people are often older, often female, and if you can picture their echocardiograms, these are the people with the large left and right atria often and the small ventricles. These people can have tricuspid regurgitation. So let's just talk now about the annulus. When the tricuspid annulus dilates, it dilates along the RV free wall. The septal portion of the annulus is relatively fixed due to the fact that it is against the septum. According to the valvular heart disease guidelines, we should measure the tricuspid annulus in the apical four-chamber view from hinge point to hinge point, as you can see here. A diastolic diameter of more than 40 millimeters or more than 21 millimeters per meter squared indicates significant annular dilation. Now, if you look at the ACC AHA 2014 valvular heart disease guidelines, they actually suggest that if you have tricuspid regurgitation and it's progressive functional tricuspid regurgitation, regardless of whether it's mild or moderate in degree, at the time of left-sided heart surgery, if there is tricuspid annulus dilation, then there's a class 2A indication for tricuspid valve repair. So in other words, what we're saying here is that it's very important to measure the tricuspid annulus because it does factor in the assessment of tricuspid valve dysfunction. Right atrium size and right ventricular size and function. Very important in the assessment of the tricuspid valve. As you saw in the previous slide, it helps you explain secondary tricuspid regurgitation, for instance. And I won't spend too much time on these because they are covered in other lectures. Suffice it to say, in this slide, this basically covers the main measurements that you would make for the right ventricle and the right atrium. So for the right ventricle, we're looking at basal and mid dimensions. For RV size, for RV function, we want to look at TAPSE, we want to look at the S prime, we want to look at the fractional area change, and for the right atrium, you want to assess the right atrial size. The guidelines actually suggest now to assess the single plane method of this volume on the right atrium. So let's pay a little bit more attention now to the assessment of tricuspid valve dysfunction. So as we said before, the most common type of tricuspid valve dysfunction is regurgitation, and that is assessed using jet area, vena contracta area, PISA method, which we'll talk about, jet density, and the hepatic veins. And then we'll spend some time on tricuspid valve stenosis. So this is a study that was performed by Nath and his group, and it's frequently quoted when talking about tricuspid regurgitation. The study included some 5,200 patients who underwent echocardiography at one of the Veterans Affairs medical centers over a period of 4 years. And what they found was that mortality increased with increasing severity of tricuspid regurgitation. So here you can see no tricuspid regurgitation, mild tricuspid regurgitation, moderate tricuspid regurgitation with increased or decreased survival, and then severe tricuspid regurgitation with even more decreased survival. So this is the ASE guidelines for valvular regurgitation published in 2017. So this is a must read for overview of echocardiographic assessment of valvular regurgitation. And most of what I'm saying about the tricuspid valve and measurement of regurgitation and stenosis comes from this document. So the jet area is really something that we all do subconsciously when reading an echocardiogram. It refers to the area of the tricuspid regurgitation jet in the right atrium. So as you can see here, small, narrow area, mild tricuspid regurgitation. Central, moderate area, moderate tricuspid regurgitation. If you have a large jet, wall impinging, more than 10 centimeters squared in area, we are often talking about severe tricuspid regurgitation. Now, the problem is that this method depends very much on driving pressure and jet direction. And you may overestimate central jets and underestimate eccentric jets. So it's a good overall subjective assessment, but you have to take the quantitation further. Another method for tricuspid regurgitation quantitation is this one, and it's used often. It's called the vena contracta method. So when acquired from the apical four-chamber view and the RV inflow parasternal view, a tricuspid regurgitation vena contracta width of more than 0.7 centimeters is considered severe, and less than 0.3 centimeters is considered mild. And this is at a Nyquist limit of 50 to 60 centimeters per second. The pros of this method is that it is really independent of this driving pressure for a fixed orifice. It is less dependent on technical factors. It's not so hard to get. It is good for severe TR. However, the problem is that it really cannot be used in multiple jets, and that you must see this conversion zone when you're imaging. Three-dimensional color Doppler methods can also be used to measure vena contracta area and vena contracta width. And this is mentioned now in the guidelines. However, there isn't much data out there on how to use this. And also, we don't know mild or moderate severity tricuspid regurgitation. What are the numbers we should use for this? So in order to get a 3D data set such as this, what you need to do is obtain a 3D color Doppler, full volume or zoom or narrow angle data set. And then what you do is you align orthogonal planes using multiplanar reconstruction. At mid-systole, you would measure the area of the jet. One of the problems here, of course, is that there's limited spatial resolution, and that may lead to overestimation. Now, this slide shows that the 3D vena contracta area of 0.3 centimeters squared was the best cutoff value for severe tricuspid regurgitation, with an 89% specificity and 84%, with a sensitivity of 89% and a specificity of 84% in predicting severe tricuspid regurgitation. So what the guidelines tell us is that a vena contracta area of greater than 0.4 centimeters squared is a reasonable cutoff for severe tricuspid regurgitation based on currently available data. Now, another method for quantifying tricuspid regurgitation is the use of the PISA method, the proximal isovelocity flow convergence method. The PISA method is based on the concept that in valvular regurgitation, blood flow converges towards the regurgitant orifice, forming these concentric, roughly hemispheric shells of increasing velocity and decreasing surface area, as you can see here. The flow rate at a surface of a hemispheric shell with the same flow velocity, or the isovelocity, as you can see here, should be equal to the flow rate across the regurgitant orifice. So by adjusting the Nyquist limit here of the color flow map, the flow velocity of one of these hemispheric surfaces can be obtained, and that way we can use that to calculate the effective regurgitant orifice area. So this you do need to know, and I think it will come up again in the lecture on formulas, but you use the aliasing velocity, which is the isovelocity that we talked about in the previous slide, that PISA radius, and to obtain the regurgitant flow, 2 pi r squared multiplied by the aliasing velocity. The effective regurgitant orifice area then is the regurgitant flow divided by the peak regurgitant velocity. The peak regurgitant velocity is used because really the PISA method obtains the flow at the peak or mid-systole, and that is approximately where this peak velocity is located as well. Regurgitant volume then is the effective regurgitant orifice area multiplied by the VTI of the regurgitant jet. Now, the pros of this method is that it is rapid, it is quantitative, but the problem is that it's not really commonly used, especially for the tricuspid valve. We do use this method a lot for the mitral valve. Also, it's problematic when there are multiple jets. And furthermore, if the PISA is not hemispheric, that can lead to underestimation of the regurgitant volume. And there's less experience with this method than there is mitral regurgitation, of course. Now, one of the things that is incorporated into the new guidelines for valvular regurgitation is this concept, that a similar effective regurgitant orifice area actually induces less regurgitant volume, and you can see that from the gray circles here, in tricuspid regurgitation than in mitral regurgitation, which is here in the black circles. And that is because of the decreasing or the decreased driving force in tricuspid regurgitation. And this is important because for the same effective regurgitant orifice area in mitral regurgitation and tricuspid regurgitation, you actually have a lower regurgitant volume for tricuspid regurgitation. So this is incorporated now in the guidelines, as you can see here. This is the effective regurgitant orifice area for tricuspid regurgitation. The thresholds for mild, moderate, and severe, as you can see, are similar to those for mitral regurgitation, with less than 0.2 being mild, 0.2 to 0.39 being moderate, and greater than equal to 0.4 being severe. However, for the regurgitant volumes, they are lower, the thresholds for mild, moderate, and severe than they are for mitral regurgitation. And you can see less than 30 being mild, 30 to 44 moderate, and greater than equal to 45 severe. So let's look at a number of non-quantitative parameters that can also help in the evaluation of tricuspid regurgitation severity. The first one here is the continuous wave Doppler signal. So we know that the signal intensity of the continuous wave Doppler jet can help distinguish between severe TR and mild TR. Remember that this density of the CW Doppler jet that we get for tricuspid regurgitation, and really for any valve regurgitation, is proportional to the number of blood cells in the jet. So if you have a faint parabolic partial jet, that is more consistent with mild tricuspid regurgitation. Whereas if you have the dense triangular early peaking jet, which is indicative of high right atrial pressure, that is more indicative of severe tricuspid regurgitation. Pulsed wave Doppler examination of the hepatic veins also helps corroborate the assessment of tricuspid regurgitation severity. And here, the insonation mean should be aligned with the hepatic vein, as you can see here. With severe tricuspid regurgitation, there is systolic flow reversal that occurs. And this you can see systolic flow reversal is flow reversal towards the probe through the hepatic vein because of severe TR. And you often see this flow reversal peaking after the QRS complex. These systolic reversals are considered very specific, more than 85% probability of severe tricuspid regurgitation when present, but they are also very insensitive. So this is the simplified flow diagram put out by the ASE valvular regurgitation guidelines to help standardize the assessment of tricuspid regurgitation. So if you can fit your patient into mild tricuspid regurgitation or severe tricuspid regurgitation, these are the relatively easier categories to fit the patient into. However, if you don't fit into these categories based on your vena contracta width, your Pisa radius, your CW Doppler jet, the hepatic vein flow, then you need to make these specific measurements. Specifically, you need to calculate the vena contracta width, effective regurgitant orifice area using the Pisa method, and the regurgitant volume. And if that tells you that somebody has mild or severe tricuspid regurgitation, then that can help you categorize your tricuspid regurgitation. However, if it doesn't fit into either one of these categories, then you have probably moderate tricuspid regurgitation. Recently, with the need to accurately quantify tricuspid regurgitation in patients being considered for the new percutaneous procedures, there's been much talk about changing the tricuspid regurgitation grading scheme to add categories such as massive tricuspid regurgitation and torrential tricuspid regurgitation. So you know, all of us who have read echocardiograms, that vena contracta width can vary in these people from, even in the severe category, from 0.8 centimeters, for instance, 1.2 centimeters, even to 2 centimeters. So it's a huge variation in the degree of severe TR. And this was actually a scheme proposed by Becky Hahn and her group, suggesting that perhaps we should break up the severe category into massive or torrential. Now, as of yet, there is no clear-cut guidelines on how to do this or what we should be doing, but there are people who are working on it. So let's move now to tricuspid stenosis. Tricuspid stenosis is currently the least common of the valvular stenotic lesions, given the low incidence of rheumatic heart disease. In regions where rheumatic heart disease is still prevalent, tricuspid stenosis is rarely an isolated disorder. More often, it is accompanied by mitral stenosis. Other causes of tricuspid stenosis, as you can see here, include infiltration, carcinoid, and then more rare causes like endocarditis, pacemakers, and so forth. The consequences of tricuspid stenosis include elevation of right atrial pressure and right-sided heart failure. Now, this is an apical four-chamber view, more of an RV-focused view in a patient with tricuspid stenosis. You can see there's also accompanying mitral stenosis there. You can see the thickening of the tricuspid valve leaflets and the doming, suggesting the commissural fusion that is seen in these patients. And One of the things that we know is that when you assess tricuspid stenosis, the most useful assessment piece is actually the CW Doppler jet in diastole. And the low parasternal RV inflow or the apical four-chamber views are the best positions to record this CW Doppler jet. So here you can see a recording from this patient. This is the TR jet. This is the TS, um, uh, the CW Doppler of tricuspid stenosis during diastole. Now, because tricuspid inflow velocities are affected by respiration, all measurements that you take in these patients should be averaged throughout the respiratory cycle or recorded at a particular point in the respiratory cycle, such as end expiration. In those patients with atrial fibrillation, measurements from a minimum of 5 cardiac cycles should be averaged. Whenever possible, it is best to assess severity of tricuspid stenosis at heart rates less than 100 beats per minute, preferably between 70 to 80 beats per minute, but sometimes that is difficult to do. The evaluation of tricuspid stenosis severity is primarily done, as we said before, by the hemodynamic information provided by that CW Doppler jet. And the hallmark of a stenotic valve is an increased transvalvular CW Doppler velocity. And you can see here that in the normal tricuspid valve, this peak inflow velocity is less than 0.7 meters per second. And in tricuspid stenosis, you can get peak velocities more than 1.0 meters per second, up to 2 meters per second with inspiration. Two of the important measurements that you can make here include the mean gradient and the pressure half-time. The pressure half-time method is applied in a manner similar to mitral stenosis, and you can actually calculate the tricuspid valve area here using, and you will remember this formula from mitral stenosis as well, except that the constant has changed 190 over the pressure half-time. Remember that the pressure half-time is defined as the time interval in milliseconds between the maximum tricuspid gradient in early diastole and the time point where the tricuspid gradient is half the maximum initial value. The decline of the velocity of the diastolic transmitral or transtricuspid blood flow is inversely proportional to the valve area. So of course, a longer pressure half-time implies greater tricuspid stenosis severity, with the values of 190 frequently associated with significant or severe tricuspid stenosis. So this is a table from the valvular stenosis guidelines, which show you the findings that are indicative of hemodynamically significant tricuspid stenosis. See a mean pressure gradient greater than or equal to 5 millimeters of mercury, the VTI integral of greater than 60 centimeters, pressure half-time greater than or equal to 190 milliseconds. And you can also, like you do with the mitral valve, calculate the valve area by continuity equation, but it's not that commonly done. Then, of course, supportive findings include a dilated right atrium, at least more than moderate, and a dilated IVC. Moving on now to the pulmonary valve. So the pulmonary valve is a semilunar valve with 3 cusps. And the aim of imaging here is inspection of the valve leaflets, quantifying any valvular dysfunction such as stenosis or regurgitation, assessment of the right ventricular outflow tract, pulmonary annulus, the main pulmonary artery, the proximal PA branches, and also to assess the RV size and function. So remember, the mechanisms of pulmonary regurgitation can be primary or organic. Some of the primary cause of pulmonary regurgitation that you will see in clinical practice is associated with congenital heart disease, such as tetralogy of Fallot, and maybe status post balloon valvuloplasty for pulmonary stenosis. Rarely you can see pulmonary regurgitation associated with rheumatic heart disease, endocarditis, carcinoid, and blunt chest trauma. And then there are also secondary causes or functional pulmonary regurgitation. So how do we assess pulmonary regurgitation? Well, the quantification of pulmonary regurgitation follows some of the same imaging techniques that we use for quantification of aortic regurgitation. First of all, you can assess the color jet. So you can assess the vena contracta width, And when you assess just visually the color jet, you can see here mild pulmonary regurgitation, small color jet, and severe pulmonary regurgitation, large area color jet. Vena contractor width can also be assessed, and jet width to annulus ratio can also be assessed. Jet length can also be assessed, and jet area, as we talked about. The CW Doppler signal can also be used to quantify pulmonary regurgitation. So as we said before, remember that the density of that CW Doppler signal is proportional to the number of lead blood cells reflecting that signal. So with mild pulmonary regurgitation, you expect to see a faint signal, as you can see here. With severe pulmonary regurgitation, you expect to see a dense signal. You can also measure the pressure half time, and you can see that a pressure half time of less than 100 milliseconds is consistent with severe pulmonary regurgitation. This is based on several studies. And the pressure half time, of course, is affected by both the right ventricular and PA pressure. So you have to take those things into account. But as you can see here, the pressure half time between these two is very different. And a pressure half time of less than 100. Remember that, consistent with severe pulmonary regurgitation. Now, this is something that we don't do that often, but just like you do for aortic regurgitation, you can actually look for reversal of flow in the descending, in the branch PAs in severe pulmonary regurgitation. Now, it is important here that you visualize and sample the flow in both in the branch PAs and not in the main PA, because if you sample the flow in only the main PA, the specificity actually drops. And one study suggested that specificity dropped to 39% if you use the main PA compared to the branch PAs, where the specificity when compared to MRI for PR severity is 87%. So this is a good a good way to look for severe pulmonary regurgitation. It's not easy to do in real life. Now, in terms of quantification of pulmonary regurgitation, regurgitant volume and regurgitant fraction can be used. I think most of this will be covered in the formula lectures that you will have. However, I just wanted to put this out there so that it helps you remember it. Quantification of pulmonary regurgitation using regurgitant volume and regurgitant fraction. Basically what you're looking for is the stroke volume across the left ventricular outflow tract, providing that there's no significant regurgitation or stenosis across this valve. You would use the LVOT diameter and the LVOT VTI to compute the stroke volume across the LV outflow tract. And you do similar for the pulmonary valve. You use the RVOT diameter and the RVOT VTI. And this is a difficult thing to do. And sometimes the high right parasternal helps you acquire the entire RVOT in your sector. And if you are able to do that and to get a good RVOT VTI, then you can calculate the regurgitant volume using the stroke volume across the RVO outflow tract minus the stroke volume across the LV outflow tract. And I left this here as a calculation for you to go through, but I do believe this will be covered also in the formula section. So remember that this method is valid with multiple jets, unlike the vena contracta method. And the right ventricular outflow tract, as we mentioned before, is really the most difficult site to measure stroke volume. And in the case of aortic regurgitation, you may need to use the mitral annulus site for the stroke volume. Now, the guidelines tell us that regurgitant fraction, mild for pulmonary regurgitation quantification is less than 20%, moderate 20 to 40%, and severe greater than 40%. Finally, our last lesion, pulmonary stenosis. So pulmonary stenosis can be congenital or acquired. And probably the most common one is congenital pulmonary stenosis. The valve can be, in these patients, trileaflet, bicuspid, unicuspid, dysplastic. It's often associated with tetralogy of Fallot, double outlet RV. Peripheral pulmonary stenosis can also coexist with pulmonary stenosis, as in Noonan syndrome and Williams syndrome. And then you can also have acquired causes of pulmonary stenosis in rheumatic, carcinoid disease, and then functional pulmonary stenosis with external compression of right ventricular outflow tract. That's happened sometimes in lymphoma and so forth. Um, Proximal RVOT stenosis and supravalvular stenosis. Now, the estimation of systolic pressure gradient is defined from the transpulmonary velocity flow curve, as you can see here, using the simplified Bernoulli equation, which is 4V squared. This estimation is reliable, as shown by good correlation with invasive measurement using cardiac catheterization. Typically, peak gradients tend to be higher on Doppler echocardiography than on peak-to-peak cath gradients. So in adults, this is actually readily performed from the parasternal short axis view here. Sometimes, however, you need to find the highest PS velocity from the subcostal view. That is harder in adults, but it sometimes happens that the highest velocity is there. Also, the highest velocity can sometimes be found in a modified apical 5-chamber view, very anteriorly directed, so you catch um, the pulmonary valve, and sometimes you can find the highest velocity here. So what is important here is this peak velocity or peak gradient, and you can see here that mild is less than 36 millimeters of mercury, moderate 36 to 64 millimeters of mercury, and severe 64 millimeters of mercury. Now, this is a classic question. It is something that we should all know how to do. Remember that systolic PA pressure is equal to the RV systolic pressure if there is no pulmonary stenosis. However, if you have pulmonary stenosis or subvalvular stenosis or so forth, you need to subtract that from the right ventricular systolic pressure in order to calculate your systolic PA pressure. And this is a very common question on the exam. And with that, I would like to thank you for your attention.